This training will review the behavioral emergencies approach. For overview, we'll look at situational definitions, a small case review, your priorities for these calls, the update to the treatment/guideline, and then some small additional information. Situational definition. We're terming it situational definition because in order for it to qualify as behavioral emergency, there has to be some criteria met. This means that you're going to intervene, either give medications or restrain the patient. We want to make sure that you're doing that appropriately. So let's look at this. So first part of this is patient's behavior places the providers at risk of harm. The patient's behavior places themselves at risk of harm. And this behavior is not physiologic or pharmacologic in etiology. So not reversible, nothing that you can do something about. So these are the patients that are likely, not possible, but likely going to cause harm to themselves or you, and you can't stop it. So you're going to have to intervene for the safety of the situation. So that's what we're looking at when we're talking about a behavioral emergency. For the case review, we'll look at a MVA from 2021. This involved a 19-year-old female. She was the victim of a head-on NVA. On scene, they administered 500 milligrams ketamine IV, and they're being sued, the providers are, that is, for causing an anoxic brain injury. So here's a little quote from this article I read. First responders allegedly failed to give Donner bag mouth valve ventilation, causing a fatal anoxic brain injury. Donner never regained consciousness and was pronounced dead at the Intermountain Healthcare facility in Murray, and around 29 hours later, according to the lawsuit. The opposing driver tested positive and was admitting on scene to methamphetamines. He was convicted of murder and 9 additional charges. It's hard to say what would have happened to Donner, the 19-year-old victim, but because they administered the ketamine and they did not have proper monitoring on her, they also caused an additional injury. So it's really going to be hard to prove that it was them versus them, but this could have been avoided simply by just providing proper monitoring and ensuring air patency. Ketamine is kind of was told to us when we got it some years back that it was the super drug and there's no side effects and it's perfect. And of course, that's not the case of anything. It's about how you utilize it. Most of the negative side effects can be mitigated simply by the way that you administer it, like speed and route and such. So this is kind of one example of many of these, like in the news about how ketamine is causing all these deaths. But really, the problem is training. These people are not using this medication adequately, and they're not doing their jobs, which is if we give them medication that can affect breathing or just level of consciousness, really, we have to be monitoring specifically end-tidal, but also heart rate, blood pressure, Q5 minutes, SpO2, and then potentially a temperature. If you want to, you can read the article. It's rather short. There's links at the bottom of this slide. For the priorities, this is talking about the priorities for you, not for the patient. So number one, as always, I know it's stupid NREMT, BSIC safety, but these situations really do warrant this, is provide a safe environment, meaning that don't go into a situation in which you can get hurt. Now, we're going to have to respond and take care of the patients, of course, but we can always wait for law enforcement, ask for additional ambulance help if you can't get that. Make sure that you've done everything you can to ensure the safety before you put yourself in a situation in which you can get hurt. Next, the least invasive treatment. So that whole BLS before ALS thing, that really rings true, particularly in these patients. Any of the potential problems that we're talking about in these calls is because we gave a medication or we restrained somebody. So if you can avoid that by doing some voodoo magic and talking them down and cooperating, that is the absolute primary priority to do. Of course, that won't always happen, and you will have to at some point sedate them and or restrain them. Next, needle safety. We'll talk more about this in the protocol section of this, but we're going to be doing IM only for behavioral emergencies, so I want you to really think about how you're going to administer IM medications with the needle when someone's being aggressive. So it's going to be generally you and a partner or more people, and ensure that you don't also stick yourself. Next, monitoring. It's all about monitoring here. We're talking primarily about end-tidal, but really a full set and that you're on it. Have the alarms on the monitor set to alert you if something happens. If you're monitoring the patient, all of these issues with ketamine that people were killing all these people, it's really just poor management because they're not monitoring. If you monitor and you have the alarms, you'll know that you'll have to take over and breathe if they stop breathing. And the last part is airway. This is really all about airway. If someone is also very drunk, ETOH, and you give them ketamine, the chances or incidence of becoming apneic is much higher than if you just give them ketamine alone. So you won't always know that. There could be polypharm too, and so it's really hard to know. Again, back to the monitoring. Airway and monitoring, you'll never have a problem with these patients. Treatment and guideline update. This will be live in the PPP app as of 5/1/0700. Remember, you have to hit update for it to populate in the app. So the big change here is that we're doing IM only ketamine and one dose, 5 milligrams per kilogram. That's two reasons. The primary reason is by giving it IM, the potential side effect of apnea and hypotension is really well mitigated. It basically won't happen if you look at it from a statistical standpoint. The second reason is, in order to give ketamine IV, you should be giving it over 60 to 90 seconds to prevent these potential side effects. In a behavioral emergency, if you had 60 to 90 seconds, you shouldn't be giving any medication because it's not a true behavioral emergency. And so what we've done here is we kind of laid it out in a stepwise fashion. So first line, you give ketamine. Second line, you're going to give Versed, and then we'll add on the adjuncts. Again, reference the protocol here in a second to look at those. Next, in-title monitoring is absolutely required. This is going to be a big deal if you don't do this. If you are monitoring them appropriately, particularly in-title, and you have the alarm set, the apnea alarm, the chances of them having a anoxic brain injury from apnea is basically gone because you'll know and then breathe for them. And the second part here is we're going to be documenting a pre and post RAS assessments, and we'll look at that in the guideline here in a second. This is the updated M13 guideline. I want to just point out the changes to this guideline. So in the general comments section, the verbiage has changed and it really mentions what specific monitoring you're required to do. So let's review that. Blood pressure every 5 minutes, at least a 4-lead ECG, SpO2, end-tidal, and then temperature. The temperature is not from the medications that we administer, it's from what the patients may have taken that can cause hyperthermia. So that way you're aware of that situation if it's occurring. Next, down to the ILS level care, the medication route is changed to IM only versus IV IM. Down to the ALS specific care is what I want to focus on. So first line, medication every time we're going to give ketamine. That's IM only, 5 milligrams per kilogram. And here it says, prepare to redose prior to dropping below therapeutic level. Estimated time between that is 15 to 20 minutes. What that means is, when we give a medication, we're trying to have an effect. If you have the desired effect, that's termed therapeutic level. That's giving enough medication to get into the range to where it's giving us the desired effect. As the time goes on, the body will process the medication and will drift below the therapeutic level. And in our case, for behavioral emergencies, they will return to being aggressive. So we want to give more medication before that happens. So make sure we have it drawn up and ready to go. Okay, next says if the RAS score is not 0 to -2, then we need to administer Versed. So again, just review. First line ketamine. If we don't get our RAS goal of 0 to -2, then we're going to give Versed. And don't worry about RAS score. We're going to review it here at the end of this guideline review. Okay, the Versed has not changed from previously, other than the fact that it's addition that it's second line instead of kind of provider judgment. Dosages are the same. Just for some reference here, I would prefer an IM route just for the same reasons of giving ketamine IM versus IV as side effect mitigation. If we are to this point and we still do not have that RAS goal of 0 to -2, then we're going to look at some adjuncts. The adjuncts I want you to think about for these situations is giving Phenergan and or fentanyl, and the doses are here for you to read. They're the same as normal. So last part, again, it says it again, required for all patients. Have to have this monitoring. Blood pressure every 5 minutes, 4-lead, SpO2, end-tidal, and temperature. All right. So the RASS scale stands for Richmond Agitation Sedation Scale. This is used a lot in the ICUs when patients are intubated, primarily what used for to determine how much medication to give. So you can titrate to this desired effect. It gives a numerical value so that you can give more or less medication. So let's look at this. Basically, for behavior emergencies, everyone that you're going to be giving medications to needs to be a +3 or a +4. You cannot talk them down. They're aggressive, violent. Again, back to our situational definition here is that it can cause harm to you or to them. So we're going to give medication. So we need to have a scale to see if we're getting the therapeutic desired effect we want. And so in this case, our goal here is a 0 to -2. So we're going to review those. 0 is BUMI, alert and calm. We follow commands. We can be redirected easily, no problem. A -1, they awaken to voice, and with the eye opening, they provide eye contact for greater than 10 seconds before drifting back off. A -2, same thing, eye opening, but the eye contact and eye opening is less than 10 seconds. So that's kind of what we want. This really drowsy or calm person, not somebody that is unarousable and potentially could have an airway compromise. So that's kind of why we use the scale and what the scale is and why it's used. Please read this guideline in entirety as you are responsible for it. For the additionals, just a couple of review points here. Last time I'll say it, but ketamine, IM only. Do not give it IV for these people, especially in this dose. Just to talk about before, if you have the ability to give it IV, over 60 to 90 seconds, then you probably shouldn't be giving the medication. If you don't do that, you give it IV fast, the chances of hypotension and airway compromise are really high, particularly in comparison to the IM route. For patients that are chronic E2H users, they are notoriously resistant to ketamine, so they're either going to need a lot more ketamine or more of a different drug, in our case, Versed. Documentation, you have to state why this patient requires behavioral control. You have to state it. You're taking their ability to care for themselves away when you sedate them. So you have to explain why that you did that. You document the treatment and de-escalation techniques. The BLS to ALS has to be documented in the chart. Why you were unable to talk them down or what you tried to do before giving them the medication. And the last part, if you're going to restrain them, you have to document CMS checks every 15 minutes. I would recommend a 4-point restraint on patients that are, again, potentially causing harm to you or to themselves. If you're giving medications to sedate them, they have to be restrained. The reasoning here is, we talked about coming out of the therapeutic range, waking up being aggressive, or enough stimulus is applied from the ambulance or environment or wherever that they wake up and they can become aggressive. So if you sedate them with medications, they need to go in restraints. I recommend 4-point. Last time, say it here, monitor, monitor, monitor. All of the issues, all this news about ketamine being horrible is just simply because people were not doing their jobs. You have to be monitoring the patient. I recommend setting alarms on these patients too, just so you don't get caught with your pants down. This concludes the Behavioral Emergencies Approach training video.